my craving. It does everything this bag says it's going to do, and it's delicious. This chocolate tastes exactly.
Hello, my friends. Jill Osborne, Interstitial Cystitis Network. It's time for another support group meeting. Hold on, getting my act together here. There we go. Hello, my friends. How are you? Let's see here. I'm doing my thing. Honey, I can't do that right now. I'm doing my support group meeting.
Oh, is it Sunday?
Yes, it's Sunday.
Oh.
Okay. So go eat your breakfast. You have to save that for tomorrow. Hello. Alrighty then. Hi, Cindy. Hello, Barbara. How are you? That was my mom. She came in thinking she forgot it was Sunday. That's what happens when you're 92. Alrighty then. Whew. Well, I'm a little bit walking wounded today because I've been doing long walks after dinner this week, and I finally hurt myself. It is what it is. Life is so funny, right? Hello, Facebook. Hello, YouTube. All right. So let me just introduce myself. I am Jill Osborne. I'm the National IC Support Group Leader and President and Founder of the Interstitial Cystitis Network. My purpose in doing these meetings is to make you so strong, knowledgeable, informed that no one can mess with you again. I don't want anybody to be able to minimize you, tell you that it's all in your head, et cetera, et cetera, et cetera. I bring to you 3 college degrees, a degree in chemistry, a degree in pharmacology, drug development, master's degree in psychology, and yes, the IC Network was my doctoral dissertation proposal. Here, let me shut this door. Which is really quite ironic because I was in so much pain I couldn't drive to school to do it. So it's really quite happy that my little old doctoral dissertation proposal from 1994 was rated #1 in the world by Harvard Medical School and the University of London. I'm going to keep, that's important for me to remind myself that, because there are moments when things are a little lonely, and there are moments when you think you could do more or you should be doing more. I'm just like you guys. Hello, Ruth. Hello, David. Hello, Nicole. Hello, Natalie. Nice to see you, my friends. Nice to see you. I hope that life is treating you well. Hello, Marlea. Hello, Elizabeth. Hi, Joan. Hi, Jennifer from Wisconsin, the great state of Wisconsin. Hello. All righty. So normally when I do these meetings, I have a 30-minute kind of intro lecture, and then I usually take questions for a couple of hours, and we switch on over to YouTube, or to Zoom or whatever. Let's see here. What did I? I'm kind of in a brain fog. Hold on. Sue says, I joined at the hero level. I'm in so much trouble, Julia. I've got a ganglion injection, so much pain. What is wrong? I'm desperate. Well, I tell you what, Sue, let's talk about that. Let's use Sue as our little intro. So you guys, now listen, here's the deal. You are an anatomical mystery to be solved. Even though you have bladder symptoms, you should not be assuming that it is your bladder. Why? Because we no longer think of IC as an incurable bladder disease. We think of it as a pelvic pain syndrome. Why? Because structures outside of the bladder are often involved, if not more involved than most of us than we realize. Whether it's muscles, whether it's bones, whether it's nerves, whether it's blood vessels, et cetera, et cetera. When you are struggling with pelvic pain, you have got to be the squeaky wheel. You have got to be asking lots of questions, and you have got to be broad-minded, for lack of a better term. Let's think about this for a moment. If you were diagnosed with IC 20 years ago, and you were faithful, you've done your Elmeron, you've done your Atarax, you've done your hydroxyzine for 20 years, but you're really not better. And in fact, maybe you're a little bit worse. At some point in time, you've got to ask the question, why? Why haven't I responded to bladder therapies? Interestingly, if you were to read the American Urology Association guidelines for IC, which were created in 2011 and revised in 2014, they make a very important point. They make a couple of really important points. Point number one is if you're not responding to therapy, for God's sake, stop it. You don't have to put your money, thousands of dollars worth, into a medication that's not helping you. If you're getting worse rather than better, it's time to take a step back, revisit the diagnosis, and let's just see, did we miss something? Could we have missed something? Is that indeed possible? And so it reminds me of the gentleman, for example, that I was working with. I told the story on Thursday. I worked with last week, who had been diagnosed with IC. He'd suffered with pretty intense pain for several years, was pretty despondent. Bladder therapies weren't working for him. So, he heard about me. So he gave me a phone call. So we started talking and chatting, and I did my normal routine where I ask a lot of questions. And one of the most important questions I ask is, where is your pain? Where is it? Is it to the left? Is it to the right? Is it on your skin? Is it inside of your body? He immediately said, it's to the right. I'm like, okay. I want you to put your hand on the pain and tell me where your hand is. He goes, it's on my hip bone. I said, well, sir, that's not your bladder. Your bladder is not by your hip bone. Your bladder is in the center of your body. You are pressing 5 inches to the right of where your bladder is. And he was stunned. He goes, but I thought it was my bladder. And I went, well, no. What's over there is your appendix and various muscles and fascia and stuff like that. But your bladder is not on the inside of your right hip bone. And his story is an important story for us all because, number one, we have to know our anatomy. You have to know your anatomy. Where is your urethra? Is it in front of your vagina or is it behind your vagina? Well, of course, it's in front of your it's in front of your vagina, but it's behind your clitoris if you're a woman, right? And it made me very frustrated on his behalf because nobody ever really asked him, where is your pain? He was just getting up at night, and it was just interesting. So let's get back to Sue here for a moment. So Sue had a ganglion injection and so much pain. What is wrong? I'm desperate. So Sue, follow me here. I want you to tell me where your pain is. The inside of your body or on the outside of your body? Okay, so Peony here on YouTube says her pain is to the right and deep. It's about 5 finger widths from your right hip bone. So it's maybe halfway in between your hip bone and your bladder. So we have to think about structures that would be in that area, Peony. And kind of the structure that comes to mind maybe it's an ovary. Although could be a kidney, although kidneys will cause more back pain. But I have to wonder if an ovary is involved because bladder pain is centered. It is centered. Anything to the right or to the left of center, we're really going to be looking first at muscles. We're going to be looking at any other structures that are going to be in that location. And your job when you go to the doctor is tell me what is at this location. Why is it hurting here? So Peony says her CAT scan came back clear. That's good. So you don't have any masses or apparently ovarian cysts. So now what's going on with your muscles? What's going on with your muscles there? Because you've got muscles there. Okay, so let's see. Hello, Anne. Anne started estrace. It's not terrible on a daily basis for flares and frequency. Can I stop cold turkey? Can you stop cold turkey? What, the estrace? I don't know. You have to be more specific, Debbie. And remember, my job is not to give you medical advice. I really can't tell you dosages or when to start or when to stop. I can only give you context and send you back to your doctor or back to your pharmacist with a better question. Natalie says, am I familiar with relief factor? somebody showed it to me, I think like a week ago, but I've now forgotten what it is. All right. Hi, Debbie. Joan says, sometimes I have a flare-up. Sometimes it turns out to be an infection. I had 4 flare-ups this year. Half were infections, going for cystoscopy in a few weeks. Don't know if it's necessary. Anne says, I'm afraid to keep using estrace. Is my mammo because is a mammogram required before starting this? Well, honey, I need you to Google topical estrogen safety. Topical estrogen safety, if you look at the research, is considered remarkably safe. So I'm not, me personally, I use topical estrogen several times a week. Am I worried about it? No, I'm really not worried about it at all because the research shows that it stays in the tissue. I've never heard of anybody requiring a mammogram before starting estrace, but if you have any doubts, ask your doctor, ask the pharmacist, but I'm not aware, nobody ever required that for me. Okay, so we're still waiting for Sue. So Sue on Facebook says that she is in terrible pain. What is wrong? I'm desperate. And so Sue, we asked you, where is your pain located? Is it inside of your body or is it on the outside of the body? And is it centered or is it to the left or right of center? Hello, John from Wisconsin. So nice to see you. Peony says, I'm in pelvic physical therapy, only going for 4 weeks and not much improvement, but I'm still going to try. The pain I'm in is horrible. Pelvic floor. So guys, when you're doing pelvic floor work, so remember when we started off these meetings, we were talking about IC as pelvic pain disorder, right? Because structures outside of the bladder are often involved, particularly muscles. And so when you go to a physical therapist for the first time, their job is to study your anatomy. Their job is to touch muscles. Let's see if they can replicate the pain. If they can touch a muscle and that reproduces your pain, that is what I call your hallelujah moment. That is super, super, super exciting. That is super exciting because it means they found it. So like this morning for me, I'm having a lot of left side pain. And I've already been, because I did a really long walk last night. I probably walked 5 miles last night after dinner. And that sometimes tweaks my pelvic floor. And I had to get down and do my stretches on my left side and roll on a tennis ball on my left side to really try to work on that. Okay, so again, at that first appointment, they're going to be touching muscles. If they can trigger the pain, that is your hallelujah moment. That is super, super, super exciting. Now, you have to understand that for some of you, your muscles have been tight for years, decades, in fact. If you've had vaginismus, if you're literally a woman, you've never had a comfortable sex. Sex has always been painful. You've dreaded going and having your pelvic because you know the moment they stick that speculum inside your vagina, it's going to hurt like hell. That's vaginismus. That's tight muscles that often begin right in childhood, just first because of something that happened in childhood, or maybe a birth defect or whatever, or, falling on your tailbone and breaking your tailbone, things like that. Those muscles received a trauma and they're locked down tight. But now you're 40 years old and you've had muscles that have been locked down tight for a long time. It's going to take a lot of pelvic floor work to restore healthy muscle tone. And it's not just you going to the physical therapist. It's about you doing all the things that the physical therapist is telling you to do. The most important part of physical therapy really isn't going to the PT. It's what you do when you get home. Are you using your wand? Are you doing the exercises on a daily basis to try to restore muscle tone? It's a journey here. It's a journey. It takes a lot of effort and a lot of commitment to try to restore those to restore muscle tone. But when we do restore muscle tone, what happens is we have dramatically improved blood supply. And that's when the bladder really starts to respond and get much better because it's got good blood supply. Selena says, I just started Elmeron. I feel like it's making me pee more. Selena, Elmeron is... an older oral therapy for interstitial cystitis, but however, it has been linked to very severe eye damage and blindness. And so it's really not being used that much now. I don't know why it would make you pee more, but I think that it's very important that you come on over to our website, icnetwork.org, and you take a look at the very serious concerns that we have. The very, very serious concerns we have now about Elmiron causing eye issues. Sierra, I emailed you, honey, over the last week. You sent me your email, but you did not send me your snail mail address. So I could not send you the book because I don't have your mail address, not your email address, your physical mail address. So Sierra, could you please email me your mailing address so that I can send you the book IC 101 that we said we would do last weekend? It's still being prescribed. Natalie said, I didn't think Elmiron was still being prescribed because of the class action lawsuit. There are over 500 lawsuits now, or 500 patients who are now suing the company and various people involved with Elmiron because of changes to their vision. It's called pigmentary maculopathy, hon, where apparently the Elmiron, or a byproduct of the Elmiron, ends up attaching to the retinas, and it changes the color of the retinas, and it damages the retina, so you can't see easily. Get bloody vision. The number one symptom is difficulty going from bright light to low light. If you're having trouble adjusting going from bright light to low light, that is one of the very, very first symptoms of this Elmiron-induced pigmentary maculopathy. It can cause fuzzy vision. It can cause blind spots. It can cause little lines. There are lots of other little retinal symptoms that can happen. Sue, thank you so much for those stars. I really, really appreciate that. Elise says, Elmiron is still being prescribed to many Norwegian patients. I declined after learning about the side effects from you. Yeah, you got to understand that, well, actually in the European Union, when Elmiron was approved, I think last year or late the year before that, they actually put a warning in the Elmiron approval for eye damage in the European Union. The question is, are the patients reading it? All right, let's see here. So we're going back to Sue. Here, but hold on. I just want to address a couple of these questions before I come back to you, Sue. Okay. Joan says, sometimes I have a flare-up. Sometimes it turns out to be an infection. You're going for a cysto. Okay, so Joan, if you are of a certain age and you are menopausal, you've aged out and you're postmenopausal, or you're on birth control, or you've had hysterectomy, or you're on chemical menopause due to Lupron, that is going to potentially make you more vulnerable to UTI. And so you want to make sure that you have somebody look at your skin down there, because if your skin is weak, and the mucosal barrier is thinner, it's going to be much easier for you to get UTI. Anne says, I'm afraid to keep using S-rays. Okay, I wouldn't be afraid of it. Honestly, go look at the research. Jill says, my urologist said I need a hysterectomy. That is why I pee so much, and I'm an IC patient. What? Well, so the only context for that is, do you have a fibroid tumor pushing on your bladder, or do you have endometriosis? That's a pretty controversial statement. I mean, you need a little bit more information than that. But again, if you've got a cystocele, you've got prolapse, your uterus is out of place. Sometimes, and I have a new blog on our website that I put out a couple of weeks ago of a woman whose uterus had lost one of its attachments. The ligament had broken, and so her uterus rotated. It reversed. And so the front was facing back and the back was facing front. And she had very severe bladder symptoms, and she had very, very severe pain, as well as a prolapse. And what was amazing is when they went in and they restored the ligament and anchored her uterus correctly, all of her pain went away, her Hunner's lesions went away, and she was cured. So we need a little bit more information, Jill, about what specifically is he trying to address with the hysterectomy. Laura said, my pain is centered, but it's above my pelvic bone and below my belly button. I look pregnant. So, honey, there are, that's fairly common. Now, that's pointing us a little bit more closely to your bladder. But we also still have to consider muscles. You still have to consider muscles because you got muscles that go from left to right. You got muscles that go from front to back. You got muscles that go to low to high. There are structures that are also involved, that also in the pelvis that could potentially be involved. Oh, you can tell. You guys. I'm a little off today. I'm in some pain because of my left pelvic floor right now. So please bear with me. In fact, hold on. I got to stretch. Oh. Hold on a sec. Let me just stretch. Oh. Oh, the joys. The joys of pelvic floor dysfunction. Okay. It's just my left butt cheek. It's ridiculous. Hold on. Okay, that's better. Okay. All righty. See? We are in this together. All righty. Danielle says, is it normal for IC patients to be highly sensitive to abdominal examinations from doctors? I scream with pain. It's horrible. Yeah, we can get something. We can get kind of a localized nerve reaction where all the nerves in the area become sensitive also. And so I would have to wonder if perhaps that is happening for you. I went through a period where for about 2 months, a month, 6 weeks, 2 months, you couldn't touch me anywhere from my crotch to my belly button. Even the softest touch hurt. And that is called allodynia. And that means that the nerves proximal to where the problem is are also becoming involved and sensitive. Nicole said this only started after a UTI in July. So Nicole, remember that when you have a urinary tract infection, that tissues are damaged and it takes time for the bladder wall to repair itself. And if you went back to drinking coffee and cranberry juice, it may simply be that your bladder has not had time to repair itself. The bladder is not going to heal well if you're pouring acid on it all day. Okay, no, so let's get back to Sue here. So Sue, we started the meeting with Sue. She was having terrible, terrible pain. I asked her, where is your pain located? She says, outside of my body, perineum, rectal, vulvar burning. You've had a total hysterectomy. You've had a left hip replacement, but the pain is centered. Okay, but the pain might be centered, but you just said it's on the outside of your body, Sue, that it's not inside of your body. It's on the outside of your body, on your perineum, rectum, and vulva. And you've had a total hysterectomy. So the consequences of a total hysterectomy is that you are now you're now menopausal, postmenopausal. It's amazing. I had a hysterectomy 4 years ago, and it's like you age 10 years in a year after hysterectomy. It's stunning how quickly things happen. So basically what's going on now is that your skin has become extremely dry. And unfortunately, it can't defend itself from the normal irritants that might be in your urine, as well as from UTI, as well as from laundry detergent, fabric softener, any chemicals that might be touching your mucous membranes down there have the potential of triggering pain. I've had a lot of rectal, I mean, guys, I have no shame. Okay, so early on, the part of my body that hurt the most was my perineum, that little piece of tissue between the vagina and the rectum. And I'm telling you, that felt like somebody had used sandpaper and rubbed the skin off. It was so severe. And ironically, that's now gone. And now for me, I have more rectal burning. And my rectal burning is really related to two things. It's related to the fact that my levator ana muscles are very, very tight. It's something I'm having to work on. And the more I sit, the worse it gets. Combined with the fact that, I'm also older now and I'm also struggling with some skin issues down there. But the fact that you have pain on the outside of your body, on your perineum, rectum, and vulva, first thing we look at is the quality and health of your skin The second thing that we have to look at is the health of your levator ani muscles. Are your muscles tight? Are they spasming? A muscle that's working hard is a muscle that builds up lactic acid that causes a burning sensation. So the question that I would be asking you, Sue, is when you go to pee, can you start your stream right away, or do you hesitate 5, 10, 15, 20 seconds before you can release your urine? That's okay. So Sue, that's my next question for you. When you go to urinate, can you start your stream right away, or do you hesitate 5, 10, 15, 20, 30 seconds before you can release urine? Okay. Pamela says, what's the email address for the book, hun? I've done the book giveaways from last week. I don't think we're going to do any today. Anybody needs to get a hold of me, icnetwork@mac.com. You know I'm a freaking soft touch. You can always email me and tell me your circumstances. And where there's a will, there's a way. You never know. I might just email you the book back. So icnetwork@mac.com. Donna said, I was cured for 8 months with pelvic floor physical therapy. Then all of a sudden, IC came back. So I went to the urogynecologist. She did an exam and found a pylon. You sent it off. You ended up with cervical cancer. Had to have a total hysterectomy in January 2021. Honey, I'm so sorry. I went through the same thing 4 years ago. I started pelvic floor physical therapy again, hoping it would go away, but it hasn't. Should I just keep doing my exercises at home, or should I go to another physical therapist? So here's the thing, Donna, you know, recovery from hysterectomy is really a year-long process. I could not have done physical therapy the first 10 months. I was in massive levator spasm, involuntary levator spasms. And you also have to understand that having hysterectomy is really brutal. Even though the doctors say it's not that bad, come on, fundamentally, it's a pretty brutal surgery. I mean, they basically cut tendons, cut ligaments, cut blood vessel, traumatized muscle, traumatized nerves. And as you know, after hysterectomy, you're walking around holding your belly for months afterwards going, "Ooh, what the hell happened down there?" You know, it's like, oh. So it's completely reasonable for you to be doing pelvic floor physical therapy, but it's also important that you understand that these muscles are still somewhat traumatized, and you're going to have to be slow and gentle, and most of all be persistent. I will tell you quite honestly that I still have levator antispasms from my hysterectomy 4 years. It's not every day, at least once a week though. I feel that pulling sensation deep in my vagina, and it drives me crazy. I would love for it to go away, but nope, it's not there. Maureen says, don't know if this is unique to me or not, but I'm wondering, have you ever heard of people having constant diarrhea while taking UroMP? I have to look up UroMP. Hold on. And you know what? The reason why I was slow getting on today is my mouse died and I had to hunt up another mouse. So I have another mouse on this computer, but it's very slow. Hold on. UroMP, what is that? MP? Well, according to 2020, the drug has not been found by the FDA to be safe and effective. Is it Urabel? Hold on. Oh, it's methenamine. It's an antibacterial drug. It's got salicylate for aspirin. It's got hyoscine for an antispasmodic UTI. It has hyoscine for an antispasmodic, and then if you have a UTI, an antibiotic is prescribed, not this. So, honey, that's not a treatment for IC so much. It's certainly not mentioned in the AUA guidelines as a treatment for IC. So the question is have I heard people having constant diarrhea? Well, let's take a look here. What are the side effects? Nausea, vomiting, dry mouth, dizziness, drowsiness, blurred vision, constipation. Causes urine and stool to turn blue-green. Tell your doctor right away if you have hot, dry, flushed skin, decreased sweating, eye pain, difficult urination, signs of kidney problems. Get medical help right away if you have very serious side effects, including easy bruising, black or tarry stools. That's important. So Maureen, when you look at your stool, is it dark? Is it black? Then that means you could be bleeding from it. Can cause high blood pressure, severe headache, chest pain, sudden sensitivity to light. Go to drugs.com or go to WebMD or drugs.com and you can look at it. I mean, I would, if I were you, I would certainly let your doctor know tomorrow that you're really struggling with diarrhea. I don't know why that's happening. And you don't know why that's happening. And so let's get your doctor involved and see if they can figure it out. So why is estrase needed to begin with if not used for sex? Because, honey, estrase is estrogen. When you give that skin estrogen, it produces mucus. Think about it this way. The bladder is the only organ in the human body designed to hold toxic waste, right? Urine is body waste. Urine contains ammonia and urea and lots of byproducts from chemicals that we're exposed to, like cigarette smoke, things like that. So how can the bladder hold ammonia for hours at a time and not get damaged? And the answer is that your bladder is like your mouth. It's a hollow organ covered with a really thick, wet coating of mucus. It's a mucous membrane organ. Your bladder, your urethra, your vulva, your vagina, and your mouth are mucous membrane organs. The purpose of the mucus is to be a barrier. It protects that skin. It makes it hard for irritants in urine to reach the fragile cells in your bladder wall. And it makes it hard for bacteria to infect the bladder, the cells in the bladder wall. So we have this wonderful, mighty mucus that protects us. Unfortunately, it's estrogen dependent. So when you're young and you have lots of estrogen, that means you have lots of mucus and you can get away with stuff because your bladder can really defend itself. But when you're older, you have much less estrogen, much less mucus. Thus, your bladder's ability to defend itself is now compromised. So foods that you might have been able to enjoy in your 30s and 40s might be too strong for your bladder in your 50s or 60s, simply because of the loss of mucus. This is known as the genitourinary syndrome of menopause. Let me say that again. Genitourinary syndrome of menopause. So, a lot of people say, well, I want to do a natural approach. Well, here's the deal. If you want to do a natural approach and give your skin what it needs to produce this nice, thick, protective coating, that's estrogen, a topical estrogen. So it's something that you have to talk with your doctor about if you're comfortable doing or not. And again, I would Google topical estrogen safety so that you can look at the research studies and make up your own decision. General, the research studies are quite good for topical estrogen as being remarkably safe. The challenge is if you don't use the estrogen down below, you're going to get drier and drier and drier. And what happens then is your bladder and your vulva and your vagina and your urethra become more and more and more sensitive. I have worked with some ladies who literally in their 80s, their little vulvas are like dry potato chips and they are in agony. And, I asked them, I said, well, didn't the doctor prescribe some estrogen? And their answer generally is yes, but they didn't use it because they didn't understand why it was important. So when you give that skin estrogen, you're giving it the critical ingredient it needs to produce mucus to defend itself. That's why we want to do that. So Jill has a prolapse. Let's see her. Marlia says, can we talk about DMannose? I understand it helps guard against E. coli bacteria. I had that bacteria a couple of years ago, treated with antibiotics. Eventually, after thinking I had a recurring UTI, now told IC for a couple of years, but I want to take DMannose to prevent future UTIs. How much is a reasonable mannose dosage for prevention? So, and will it help IC? No, DMannose will certainly not do anything for quote unquote a bladder wall injury. All DMannose is going to do is potentially help flush E. coli out of your urine. Your body does not use mannose, so it's not like a sugar that you're going to gain weight from. Literally, you swallow it. It is immediately put into your urine. It is immediately excreted. The gift of DMannose is that it has a receptor on it that matches an E. coli receptor, and so E. coli attach the mannose instead of your skin, and then you pee it out. I don't know what the dosage is of the DMannose that you're taking. The DMannose that we suggest is right here. It's called My Daily DMannose. And so let's take a look and see. As a dietary supplement, take 1 scoop 2 to 4 times a day mixed with fresh water. Can be taken with or without meals. Okay, My Daily DMannose. Now, of course, we always want to know. Let's see, how do I want to say this? DMannose has its place. But there have been research studies that have shown that DMannose is not as effective as something called proanthocyanidins, also known as PACs. PAC is an active ingredient in cranberry that also has been shown in research studies to reduce the incidence of UTI. And so if DMannose does not get you where you want to be, your next step would be to talk to your doctor about Ellura, ELLURA, or Prevent. And I have Prevent right here. These are the two most common, more aggressive anti-E. coli, anti-UTI supplements. So Prevent combines PACs with DMannose, right? And it does have some chondroitin in it for the bladder wall. It does have a few other ingredients in it too. It has chondroitin in it, quercetin in it, hyaluronic acid in it for the bladder wall. It also does have some beneficial probiotics, right? So but again, DMannose is not, okay, I'm not going to sit on this freaking, oh, I'm just cranky today. My body is cranky. All right. Okay. Sorry about that. I am human. Joan says, what topical estrogen? Well, honey, you have to talk to your doctor about the type of estrogen that they want you to use. Generally, patients use an estradiol or an estriol. Sue says, I'd like to call and talk to you. Of course, absolutely. I would love to talk with you. You're absolutely welcome to give me a phone call. I am this week. Let's see what's going on this week. Let me take a look at my schedule here. I'm booked on Wednesday, but I'm open Tuesday, Thursday, and Friday. And Sue, if you email me your phone number, maybe I can try to give you a phone call too. I haven't had a day off in almost 2 weeks right now, and I worked yesterday. I'm working today, so I kind of really need my day off tomorrow because I'm getting a little fried, to be quite honest. Jennifer said, I used to work in elementary middle school. I was not able to leave my classroom for around 2 or more hours because I could not leave my students. Thus, I had many UTIs. You know, Jennifer, we did a very, very interesting occupational study to find out what occupations IC patients had to see if we could make a correlation. And I will tell you that the number one occupation that we found that in IC patients was teaching, and the number 2 occupation was nursing. And in both contexts, it's related to the lack of restroom access, for sure, especially if you're drinking coffee. So if you're drinking coffee in the morning and then you're not allowed to use the restroom, you're really holding a lot of irritants in your bladder. God forbid you also be doing soda and stuff like that. Donna says, I always feel like I need to empty my bladder. Honey, if you have a false sense of fullness where you feel full even when you're empty, that is a kind of the equivalent of the bladder screaming at you, saying, help me, help me. When we see that false sense of fullness, that's the bladder wall really, really, really irritated. So let me describe a flare for you. So let's say you go to bed at 11. Of course, you urinate before you go to bed. You wake up an hour later, your bladder feels really, really full. You go to the bathroom, you might pee out a quarter cup of urine. You go back to bed, you wake up 30 minutes later, your bladder feels really, really full. You go to the bathroom, you might pee out a teaspoon. You go back to bed, 20 minutes later, you feel like your bladder is really, really full. You go to the bathroom, you sit on the toilet, you strain, and you get a drop. And then you're stuck in this, oh my God, my bladder feels full, but there's nothing there. And that false sense of fullness is a very common symptom of really severe bladder wall irritation. When I would have IC flares, that was a classic symptom that I went through. I wrote a blog called Anatomy of an Utterly Ridiculous IC Flare, where I had 3 strong acids that day. I was just an idiot. I was just an idiot that day. And I just had a terrible flare that night. And I had that false sense of fullness. So what do you do when you're going through that? You know, if you can, drink some water to dilute your urine and try to do that bladder wall flare protocol. We have that on our website. If you go over to icnetwork.org and sign up for our free newsletter, you can download our 40-page flare management guide, which has hour-by-hour rescue plans. Hello, Megan from South Africa, Johannesburg. Woo, it's almost midnight. Oh, thank you, hon. Thank you. Here, let's go back to to YouTube here for a moment. And I'm having trouble. I've got this really weird mouse on this computer right now. Selena says, my urologist said he thinks physical therapy won't work. Well, you won't know until you try. I mean, he's not God. He can't predict the future, just like I can't predict the future, just like you can't predict the future. I mean, what do you have to lose? Might as well go a couple of times and again, see if they can find anything interesting. If she can touch your pelvic floor and trigger pain, that's a hallelujah moment. Natalie says, I have Hunter's ulcers. They say they ruled out pelvic floor. Peony, you sound like you have a lot of similarities. Ask Jill what to ask your doctor before your hydro. If you go on over to our website, in our diagnostic section, we have a whole section on hydrodistension and the questions you want to ask your doctor before hydrodistension. Literally, I think that there are the key points you want to ask your doctor is, number one, will I have pain care? Hydrodistensions can be quite painful afterwards. Some people can go out to dinner afterwards. Others might be in bed for a week. Now, the good news is in the old days, they used to do a high pressure, long duration hydrodistension that was very, very painful. And the AUA in their guidelines admitted that traumatized a lot of patients who never returned back to their doctors. Today, we now do what we call low pressure, short duration hydrodistensions, which are not as traumatic. And so number one, how are they going to do it? Will it be high pressure or low pressure? It should be low pressure, short duration, according to the AUA. Second, will you have a little bit of pain care if necessary? And number three, what is the doctor's plan if he finds Hunter's lesions? One of the great tragedies of the IC movement are patients who have a hydrodistension, they find Hunter's lesions, but they don't treat them. And untreated Hunter's lesions are very, very painful. And these patients truly suffer with pain for a long period of time until those lesions are treated correctly. So normally what they do is treat the lesion when they find it. And if the doctor says, no, I'm not going to be treating them, you're going to say, why? And the odds are the doctor's going to say, because we don't have the equipment to treat them. You know, a laser, specific type of laser, fulguration, something like that. So if that's the case, and the doctor says you don't have the equipment, your next question is going to be, all right, who does have the equipment? Because it's a real shame to have it done twice. You know, I mean, if the first doctor finds it, doesn't treat it, you're still going to have to probably have them treated, which means another hydrodistension, et cetera, et cetera. So it's usually best to get it done at the same time. And that's what the American Urology Association says. Let's see here. Natalie said, when I had mine, it was done. It made me worse. That's because they did the long pressure, short duration, high pressure, long duration. Peony says, was the pain from your Hunter's concentrated from one side to the center? The pain can be on anywhere. in your bladder. It can be low in your bladder, high in your bladder, to the left or right. But again, remember, your bladder's still fairly small. It's not like it's going to be by your hip bone. Peony said the Euro would do a low pressure. Awesome. Sierra says, is it such a thing as an estrogen cream? Yes, honey. That's what we've been talking about. Estradiol. And Natalie said, I had my bladder stretched to 40%. It almost burst. I had tons of hunters and they did nothing. That's a great tragedy, Natalie. I'm so sorry that had to happen to you. That's awful. All right, let's go back to Facebook here. Anne says, when is estrogen given if not daily issues? Estrogen, your estrogen is going to be based upon the quality and health of your skin. If your skin is super, super dry, they might have you use it every day for a couple of weeks and then go back down to 3 times a day or 3 times a week or 2 times a week. But I'm only talking about topical estrogen. Pamela says, my question is, I was looking for the question I was looking for in your book is on yeast. Can you direct me to research on how to help my body with yeast? I'm on insulin. You know, I would go, honey, Pam, go to pubmed.gov, P-U-B, P as in Paul, U, B as in boy, M as in Mary, E as in Eric, D as in dog, pubmed.gov. That's the National Library of Medicine. And go in there and search for Candida, and that will give you all of the research. And you can even do Candida insulin or Candida diabetes, and you can look at all of the research studies that have talked about that. Kayleen says, I have a 6 UTI since May now. I went to the ER the other night for pelvic pain. I felt so off mentally. I couldn't get rid of the unexplainable feeling. The male ER doctor told me if I can't find a women's health specialist, I should just suck it up. Oh my God. Well, screw him. Suck it up and deal with it for the rest of my life? What a jerk. What a jerk. Although, remember, I had a doctor kind of say that to me, and that really woke me up. I had a doctor say, you will forever have to, you will forever be a burden on your family. This is your life. Get used to it. You always live in pain. That was a moment that I went, I will prove you wrong, you son of a bitch. How dare you say that to me? And that's when I started reading the research. Oh, honey, I wish I was sitting right next to you. I'm so sorry. Oh. Oh, honey, honey, honey. Let's talk, girl. I think you really need to go see a specialist at this point in time. I mean, Ken Peters in Michigan. I mean, at this point in time, your pelvis is in sorry shape. Kayleen, just for those of you who are listening and watching, Kayleen is one of our dearest members, and she's really, really been struggling. She's got compressed discs in her back, and she's so she has a lot of back pain. She's got muscle issues. She's got UTI issues, and it is wearing her. You girl, you are a trooper. You are like the epitome of, almost a Navy SEAL, what you've gone through, the training that you've gone through. We got to get you through to the other side and make you active and healthy again. So, Kayleen, if we can, would you do me a favor, honey? And would you email me icnetwork@mac.com? And I want to drop a case study of yours, and I want to send it off to some of the top doctors in the country, and let's see if we can get you into one of them, because this has gone on long enough. You know, your case is very, very complex. But the fact that your pelvic cavity is spasming and that you got the burning urination, we got to work on the UTI. They got to work on the pelvic floor, and we got to work on your back. Jennifer says if Facebook is freezing up. Bethany says, I think vaginal estrogen is causing more sensitivity inside my bladder. Do you use topical or vaginal? I use both. Well, that's the same thing. I use the same thing both inside my vagina and my urethra. So the one vaginal estrogen that is somewhat notorious for causing extra irritation is Premarin. So is it Premarin? Premarin has a lot of extra preservatives in it that can be quite irritating. Linda said, I received immunotherapy for smoldering myeloma, which really caused my condition, which really helped my condition, but caused your dormant IC to be resurrected. Horrible pain back on Elmeron after being off Elmeron for a number of years. I had to stop treatments. Does this mean I will never be able to take immunotherapy or chemotherapy? Any insights? Well, there are some forms of chemotherapy that are quite irritating to the bladder, and there are some that are fine. And so you really have to do your due diligence, ask your doctor which chemo meds they want to use, and then you've got to research it, talk to the doctor, will this irritate my bladder? There is, and I don't remember what it is off of the top of my head, but there's one chemotherapeutic agent that is absolutely notorious for causing chemocystitis, but there's also a medication they can give you that immediately blocks the ingredient that causes the irritation. Sue says, it takes sometimes several minutes to release urine. Yeah, girl, you got tight muscles. If you can't release your urine, you got tight muscles. So we also have to look at your pelvic floor. Bethany's asking about bioidentical hormone therapies. Just don't have a lot of information on it. It's not something that I've really ever gone into. Melissa says, I have a lot of pain and pressure in my vagina. The doctor told me I waited too long to treat it. I have to wait for hydrodistension. I've had more pain after a steroid. I can't think of the word. The only thing it has done is stop the leakage. Well, okay, that's important. Guys, whoo! Holy crap. Some of the, wow. I get so angry at the way some of you are being treated. I just can't believe it. The doctor, Melissa says, the doctor told me I waited too long to treat my pain. I have to wait for a hydrodistension. I've had more pain after a steroid. I can't think of the word. The only thing it's done is stop the leakage. The doctor says she knows I'm in a lot of pain, but she says she will not prescribe me anything. It's my fault because it got so bad, because I don't like to say pain unless it's too high. They also said I would not need pain meds after the hydrodistension, that whoever told me that is a liar. I don't sleep. I'm in so much pain. And in the bathroom, so much, to the point of sleep paralysis. My primary tries to step in and to say what is going on, and they called me mad because of it, saying I'm not getting pain meds. I feel beyond frustrated. Melissa, where do you live, hun? It sounds like you need to be working with a team that's a little bit more experienced working with IC and pelvic pain. Hydrodistensions, the worst thing you can do to an organ is stretch it. Think about how bad when you eat too much and your stomach hurts, right? Hollow organs, the worst thing you can do to a hollow organ is stretch it beyond its normal capacity. So hydrodistensions absolutely have the potential of triggering pain. in that post-op recovery period, whether it's a day, whether it's a week, it's possible, especially if they use more pressure. Again, the technique today is low pressure, short duration, rather than high pressure, long duration. The reason why some people are pain-free after a hydrodistension is because it breaks nerves. When you stretch the skin, the nerves in the skin are broken. And so you could potentially have a pain-free period for a couple of months after, once you get through the post-op recovery, you may notice that your bladder feels better for a couple of months because the nerves are broken. So thus they cannot communicate with your spine and tell you that there's pain. Unfortunately, the nerves always grow back. The nerves always grow back. So whether it's 2 months later, 3 months later, 4 months later, the odds are you're probably going to have symptoms again because nerves grow back. Hydrodistension is basically what I consider a destructive therapy. It's making you feel better because it's destroying something. It's destroying the nerves. That's very different from a constructive therapy. A constructive therapy is something that helps to build something. So instead of breaking something down, we're building something up. I guess our challenge here, Melissa, is we don't really know what's causing your pain. Your pain is in your vagina. So you're not saying you're having bladder pain, you're saying you have vaginal pain. And so what's happening in your vagina? Do you have a prolapse? One of our challenges here is that doctors like to play in their sandbox. Urologists like to stay in the urinary tract, gynecologists like to stay in the reproductive tract, gastroenterologists stay in the bowel, and they don't necessarily look at relationships. And it's very easy to confuse bladder pain with reproductive tract pain. And that is, in fact, why Dr. Parsons created the PUF questionnaire. And because as a tool that gynecologists could use, they have you fill out this very quick survey, it takes 30 seconds, and that will help them differentiate between bladder wall pain versus vaginal pain. Why? Because we've had some patients who have had completely inappropriate hysterectomies, only to discover after the fact that it was bladder, et cetera, et cetera. So what we really have to try to focus on is what could be driving your pain. Is it your bladder wall? Is it your pelvic floor? Is it something in your vagina? Is it something on your uterus, in your uterus, like a fibroid tumor or something like that? I think it's very, very sad that the doctor's telling you. I mean, some patients will wait too long to have like a cystocele repaired or rectocele repaired. They wait too long, and then the muscles stretch out so far. The only thing you can do is surgically repair them. You've passed the point where physical therapy would help. So I need a little bit more context there. Becky, can someone explain bioidentical estrogen as compared to what you got? I'll let you do that on your own. Vicky says, I hate this. I've gotten hooked on my iced tea again. Ooh, do your best. Marlene says, hello, I just came on. Just found out I have degenerative disc disease, L5 to S1. Any thoughts? Well, that's definitely that's an area where the nerves for your bladder and your pelvis will merge into the spinal cord. So it's very well known that if there's an issue with L4, L5, that has the potential of affecting your bladder and your bowel. When I ruptured my disc at L4 and L5 last December. The very first thing they said is, are you incontinent? Are you leaking at all? Are you leaking urine? Are you having problems with bowel movements? Because if that happens, that means that it becomes a more severe nerve issue, and they have to go in and surgically repair it. You guys, Facebook's going by real quick, so I'm playing catch up here. If I missed your question, please be patient with me and ask it again. I am still here. Yes, Jennifer says, I'm still here. Debbie says she had Hunter's lesions and fulguration a year ago, and she's 80% better. See? Exactly. Anne says, does estrogen cream help frequency in IC? Estrogen cream will help your skin produce more mucus that will then protect those nerves which are causing the frequency urgency. Estrogen does not have an effect directly on the nerves. All it's doing is making your skin more healthy. Jennifer says, I use Premarin regularly. Yeah, a lot of people have problems with Premarin. It's notorious for causing irritation. Oh, okay. Joan says, will the estradiol patch work the same as cream? No, it's really helpful to be able to put the cream directly on your skin down there. Anne says, does estrogen help with frequency? No, estrogen does not act on the alpha afferent nerve, which causes frequency. What estrogen does is it helps the body produce the mucus that protects the cell, thus protects the nerves. Okay, so if you're looking for a medication that will directly work on those nerves, you're looking at Myrbetrix or Mirabegron. You guys are tough today. I'm sorry that so many of you are struggling. Maybe it's just the moon or something, because I'm in pain too today on my left side. The doctor did my hydro, said I had one of the most severe cases he'd ever seen. I asked him what to do. He says, learn to live with it. He didn't, hopefully he treated them. Can Hunner's lesions heal on their own? They have been known to heal on their own, but they've also been known to get worse on their own and to multiply. Hunner's lesions are a bit of a mystery. We kind of have three theories about Hunner's lesions right now. Theory number one is that it's a viral infection, because we have research from Europe that for the last several years that have found the polyomavirus in the urine of patients with IC. That data was replicated in a National Institutes of Health study last year, which did indeed find polyoma viral infections in a very small subset of IC patients. So concept number one is that it could be a polyoma infection. Concept number two is that it could be a nerve that's just remarkably sensitive and irritated and inflamed. Nerves that are inflamed release a substance called substance P, which is quite damaging to tissue. So that's a possibility. And then the third possibility is that there's some sort of structural defect that is also putting great strain on nerves and or tissue, such as the woman who had posterior fornix syndrome, which means that her uterus had rotated and was facing backwards. And obviously was in that twisting motion, it caused a ripple effect of issues, including in some way triggering Hunner's lesions. And when they got the uterus back in the correct position, the Hunner's lesions healed completely. She's completely cured. It was a case study published. You can find that on our website, icnetwork.org, in our blog section. Natalie says, my pain has gotten progressively worse throughout the years. Is that common? It happens. It does happen. At the International Pelvic Pain Conference last year, they used an example. They used the same case study for all 3 days when they were talking about pelvic pain. So it was somebody in their teens who had very, very painful periods, and maybe some endometriosis. And then in her 20s, she developed irritable bowel. And then in her 30s, maybe IC. And then in her 40s, maybe vulvodynia. And over time, this woman got progressively worse. And in that context, they were really talking about chronic overlapping pain conditions and central sensitization, that in situations like that, where we see that patient getting progressively worse and developing multiple pain conditions, and I'm in this group, hon. I'm in this group. I mean, I had frequency urgency in 7th grade. I had vulvodynia in high school. I had ovarian cysts in college, IBS in my 20s, migraines, extreme sensitivity, IC when I was 32. Yeah, you know, you name it, it's happened. I'm in this group too. And what that conference and in general, what the research studies are now really focusing on is that it's our central nervous system that is what's dysfunctional. So, Natalie, let me ask you this. Do you struggle with high anxiety? Do you have anxiety disorder? Do you have anxiety? Hey, listen, I had severe anxiety disorder in my 20s. So do you have anxiety disorder? So what the research studies are showing is that we are stuck in anxiety. We are stuck in fight or flight. Patients with the chronic overlapping pain conditions, they did brain scans. The Chronic Research Alliance, the Chronic Pain Research Alliance were the first to do it. That was a collaboration of researchers with researchers who specialize in all of this group of pain conditions working together. When they did the brain scans, what they found was that the brain was stuck in the fight or flight response, that the amygdala was basically thinking that your life was at stake over and over and over. And then the IC community, they also started, the MAP Research Network also started doing brain scans about 10 years ago. And, you know, I didn't talk about them. And the reason why I didn't talk about them is, number one, I thought they were a little scary. And number two, I just didn't understand it. Although ironically, I will tell you that back in the 90s, when we were talking about a group of IC patients having an extremely sensitive sense of smell, and I knew that because that was me too. I have an extremely sensitive sense of smell, and smell is a brain function, right? And so, I knew back in the 90s that they were looking at the brain. I just didn't understand what it was. All right. So again, the Chronic Pain Research Alliance and the MAP Research Network, the federally funded IC and chronic pain, chronic pelvic pain, chronic prostatitis research group, also have found a runaway fight or flight response in our brains. And so this was the theme at the International Pelvic Pain Conference last year. And what was so interesting about it was the risk factor class. Why does this happen to some people and not others? Why did this happen to you? Why did it happen to me? But why does it not happen to other people? And what their research found was that for 80% of the kids that had this, there was a traumatic physical injury in the year prior to the onset of their chronic overlapping pain. And so Natalie says, yes, generalized anxiety disorder, very toxic. Okay, got it. Okay, so let me get through this. I'm going to make sense. This is going to make total sense for you, Natalie. And I want you to remember, none of this is your fault. Nobody's saying this is a mental illness at all. What we're saying is that the nervous system has become maladapted. They call it a maladaptation. So in the pediatric risk factor course, 80% suffered a physical injury, 20% were either abused or bullied. So let us look at what happens to the brain in bullying. So let's say that you had a bully at school, like I did. I mean, we had a kid at school who raped and murdered my neighbor. I mean, it's terrible. He hurt so many people. So many of us, when we have our high school reunions, we have survivor reunions too, because it was really bad. He was severely mentally ill. All right. So let's think about this for a moment. You have a bully at school. So as soon as you wake up in the morning on a weekday and you know you have to go to school, you go into fight or flight. And you walk out the door and now you're looking, where is he? Where is he? Where is he? Right? The closer you get to school, the more hypervigilant you become. Then once you're at school, you are extremely hypervigilant. Your brain is absolutely in fight or flight because you know you can be hurt. You know you can be hurt. When I found out he murdered my neighbor and I was away at college, I fell on the floor sobbing because I knew that could have been me. So we absolutely are extremely hypervigilant, right? Our life is at stake. So you're hypervigilant all day long, and the only break you get home, the only break you get at home is when you get home, 3 or 4 hours. And then mom says, hey, got to take a shower, got to take a bath, got to go to school tomorrow. That immediately puts you into fight or flight again. So what the research shows is that 20 days of this changes brain function for the worse. 20 days of mind-body medicine reverses that damage. It completely reverses that damage. So, and you have to really kind of understand your brain. Your brain is extremely primitive. There's not a lot of cognition happening. All your brain is doing at any given moment, any given time is paying attention to your senses. What do you smell? Do you smell a fire? What do you hear? Do you hear the bully? What do you see? Do you see a saber-toothed tiger? Right? All your brain is doing is monitoring your senses. And then it's paying attention to your history. It's applying context to what it's feeling or what it's sensing. It's like, okay, have you smelled this before? Is this a good smell or a bad smell? It's roses. It's a good smell. It's a fire. No, that's a bad smell. I got to be careful. So that extremely primitive fight or flight is basically where that brain is living. And the classic symptom is generalized anxiety, having lots and lots of anxiety. And it didn't just apply to children, it applies to adults. If you have a bully at work, if you have a bully at home, 20 days of that bullying is absolutely going to change your brain in a very clear way for the worse. 20 days of mind-body medicine reverses that damage. So, and think about fight or flight for a moment. So, chemically, basically what happens is that you see the saber-tooth tiger or the bully, and that scares you. Your sympathetic nervous system takes over. It turns the amygdala on in your brain, and you start getting adrenaline shooting through your body. What does the adrenaline do? It raises your heart rate. It raises your blood pressure. It tightens your muscles to prepare you to run for your life, to protect you, to run for your life. Normally, in a normal, healthy brain, once the fire's out, once the guy's walked away or the woman has walked away, your parasympathetic nervous system takes over and it calms everything down. It lowers your heart rate. It lowers your blood pressure. It relaxes muscles. But you and I were stuck in fight or flight. So what's exciting about this, Natalie, and for anybody watching this, what's exciting about this is we know exactly how to reverse it. We know exactly how to reverse it. And that is with good mind-body medicine, good sensory stimulation. Mary says, could eosinophilic cystitis be related to Hunner's lesions? No. Eosinophilic cystitis is a separate and distinct condition where the bladder wall is filled with white blood cells, eosinophils, not related. All right, so mind-body medicine here. So the purpose of mind-body medicine is to give the brain safe sensory information to turn off the amygdala. So let's do it. I mean, come on, guys, let's do it. Takes 5 minutes, super fun. And for those of you with chronic anxiety and you got children with chronic anxiety, this is a great exercise to do with your kids. God, I wish I'd known this when I was a kid. It really would have changed so much for me. All right, so we're going to do I Spy. Let's do I Spy. It's my favorite technique. There are lots of different mind-body medicine techniques. I like I Spy. All we're going to do is we're going to tell the brain that we're in a safe place. So how do we do that? So let's do I Spy. Okay, so I want you to pick anything in your room, anything at all in your room. So I have an owl on my as my wallpaper on my other computer. So let's just pick something safe to look at. It's an owl. It's gorgeous. I wish I could show it to you. Can I show it to you? No, I can't show it to you. Well, all right. Let's take a nice, slow, deep breath in and a deep breath out. What do you hear right now, aside from my voice? Can you hear anything in the background? Do you hear a TV on, family members talking, a car going out down the street, out your window? Take a moment and just listen. So I hear my little air conditioner right here. Okay, now let's take a nice, slow, deep breath in and deep breath out. What do you taste? Can you taste anything right now? For me, I've got my normal smoothie, which is banana, mango, a little bit of strawberry, right? Can you taste anything? And if you can't, that's okay. Take a nice, slow, deep breath in and a deep breath out. What can you smell right now? Can you smell anything? And this is where aromatherapy finally makes sense. Finally makes sense. This is where if you have a nice little, I'm not talking about Febreze or any of the heavily toxic ones. This is a nice little facial spray. It's rose. Okay, so just live with a smell, whatever you're smelling. And now let's take a nice, slow, deep breath in and a deep breath out. And now I want you to take your hand and I want you to rub it on your pants, your jeans, or your leg. Or your chair. If you're sitting on a chair that has a texture, just run it back and forth. You know, and your brain's going, okay, I don't understand why you're rubbing the chair. I don't understand why you're doing it, but there's no problem. I mean, it's just skin. It's not a big deal. Okay? So you're giving your brain good touch information, the sense of touch. Okay, now let's take a nice deep breath in and a deep breath out. All right, now comes the good part. Now comes the really, really good part. If you could look at anything that would put a smile on your face, what would that be? And for me, that would be my cat that I lost a couple years ago. Seeing her run across the floor to me when I got home from work, right? So just live in that memory for a moment. And take a nice, slow, deep breath in and a deep breath out. Hi, Shirley. All right. If you could hear something that would put a smile on your face, what would that be? Would it be your favorite music? Would it be a child laughing? Would it be the cry of an eagle or a mockingbird? Whatever. What could you hear that would put a smile on your face? I was listening to John Denver in my car yesterday. Come dance with the west wind and touch on the mountaintops. Sail o'er the canyon and up to the stars. And reach for the heavens and hope for the future. And all that we can be and not what we are. Right? That's a real smile. Okay? Deep breath in. Deep breath out. What could you smell that would put a smile on your face? That's easy. Hot cinnamon rolls, hot apple pie. Live in that for a moment. Deep breath in. Deep breath out. What could you taste that would put a smile on your face? What could you taste? Like, what's one of your favorite things to eat? I don't care if it's IC friendly or not. Just think about it. And again, hot apple pie, hot cinnamon roll does me every single time. Live there for a moment. In. Sierra says a donut. Sure. Out. And last but not least, what could you touch that would put a smile on your face? What could you touch? Your lover? Your child? Rubbing his hair? Brushing his hair? Her hair? A flower? A cat or dog? What could you touch that would put a smile on your face? Be there for a moment. In and out. So what we've just done there is that we have taken control of our brain. We have shut down fight or flight. We have shut down the sympathetic nervous system. And we have now engaged the parasympathetic nervous system. And what does that do? It calms everything down. Calms everything. Like, admit it. How do you feel right now doing that? You feel good, right? You have a smile on your face, right? There is no anxiety when you're doing I Spy. It's good sensory information in a good context, happy context. Now, another technique you can do, and again, this is about giving the brain good sensory information so that we can turn off fight or flight, is something called tapping. So let's do tapping. Let's do a routine of tapping too. You can go to go to YouTube and you can Google tapping, search for tap. Look at that. We don't even say search anymore. We just say Google. That's hysterical. Go to YouTube and you can search for tapping and you see a lot of providers who do that. Sylviane says, if you feel better, for sure. Yeah, exactly. Natalie says, Jill, my pain is literally better. Exactly. So is mine. Okay. Hi, Sandy. So let's just do tapping. So with tapping, what we're going to do is we're just going to tap on different parts of our body. And again, we're forcing our brain to break out of fight or flight. And we're just going to get it let's just say we're going to distract it. We're going to distract it with tapping. There's no threat in tapping. So with tapping, we're just going to touch different parts of our body. So we're going to start here, right at your eyebrows. So go ahead and go 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Okay, which I've now just messed my makeup up, but that's okay. Okay, now we're going to do right here. Oh, wait, no, we're going to do right here. You're going to do this bone right here. So you're not in your temple. You're on the ridge of your eye bone right here. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. And normally they would also have you repeat something like, I am strong. I am confident, right? I can do all things. Okay. Now we're going to go here. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. I can do all things through my faith that strengthens me. Okay. Now we're going to go here. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Every day, in every way, my life is getting better. Okay. Now we're going to go here. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Every day, in every way, my life is getting better. Now we're going to go here. I know I wore this dress for a reason today. Whoops. You guys, I'll figure out that I always wear sports bras, which is why you end up seeing them. Okay. Okay, you're going to go to here, which is the beginning of your collarbone, but I want you to go down about an inch and here. Right? Okay. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Okay. Then you're going to go here on the inside right here. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. And then you're going to do the top of your head. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. And again, you're normally doing that with some sort of affirmation you're saying, or if you're working on something, you know, with a therapist, this would be a great time for you to repeat that every time you do that series of 7. But they do that. They've been doing that at Harvard Medical School with very, very severe PTSD soldiers who have come back from war. And it breaks them out of fight or flight for hours and hours and hours. So while it's easy to chase the pain, and we have to be smart about it, I mean, listen, for those of us with chronic overlapping pain conditions, the last thing we want to do is caffeine, because caffeine amps up your nervous system. And this is a central nervous system disorder. We need to calm things down. We have to take responsibility on a daily basis for our stress levels. And I think most importantly, we have to understand the damage that negative thinking and anxiety causes. So the other piece of this puzzle is understanding that every single time you have a negative thought, you give yourself a jolt of adrenaline. You're turning on fight or flight. So we have got to get those negative thoughts under control. And the way we do that is by getting the adrenaline under control. So I have a really good video on our website that I did called I See an Anxiety. And it talks about the anxiety management class that I went through. I have not had a panic attack in years. I mean, in like 25 years. I used to have them every day. I used to have them before going to the doctor's appointment. And that's ultimately, in the end, there was a day where I was so sick of having that panic attack before going to the doctor. I just said, I need help. And I went and took an anxiety management class. The class was called Phobies. And the cool thing about the class is it was developed by a surgeon with anxiety disorder whose son had anxiety disorder. And he focused on anxiety management as chemistry management. He said that for those of us with anxiety disorder, we have got hundreds of jolts of adrenaline going through our bloodstream every day, because every time you have a negative thought, you give yourself a jolt of adrenaline. And so your body now is completely overwhelmed with adrenaline. It is struggling with all these, you know, stress chemicals, for lack of a better term. And so what they taught us in the class is we have to get the adrenaline under control. We got to break you out of adrenaline. You've been living with adrenaline for 20 freaking years. We got to get it out of your system. How do we do that? We have to deal with the negative thoughts. And so they taught us a really simple technique. It's a 3-step technique. It works every time. Every time you have a negative thought, the first thing you do is just close your eyes, visualize a stop sign. Just stop. Just like stop it. You're stopping your brain. Stop. Then you take a nice, slow, deep breath. In for 3 and out for 3. And that oxygen has now rendered the adrenaline from that negative thought neutral. Oxygen turns off adrenaline. So stop sign, deep breath. And then the third step is you got to remind yourself it's a thought. It has no power. So what I say to myself is, oh my God, Jill, how arrogant can you possibly be to think that you can predict the future? For all you know, tomorrow is going to be a fantastic day. And you have to remind yourself that it's a thought. It has no power. It's just a thought. And I've asked a lot of doctors, I said, why are we prone to negative thoughts? And basically they say it's a brain chemistry thing, that a negative thought is just kind of chemically easier on the brain than a positive thought, which I think is quite interesting. I'm not saying I understand exactly how that happens, but that's a good summation. Okay, so stop sign, deep breath, minimize the thought. So they then said, now listen, we have one goal, and that is to get you out of adrenaline overload. So when you leave this class today, we want you to pay attention to your thoughts. Every time you have a negative thought, stop sign, deep breath, minimize the thought. And I'm a chemist. I was interested in the chemistry. I'm like, okay, I'll do it. I was stunned. I was stunned that every other thought going through my brain was a negative thought. Every single one of them. That's like, hey, you want to go to a movie? No, it's going to hurt. Hey, you want to go out to dinner? No, it's going to flare me. Hey, you want to go take a drive? No, it's not going to be fun. No bathrooms. Hey, you want to plan a trip in a year? No, I'll never get better, right? If you got anxiety disorder, you're doing that all the time. every single time you're doing that, you're giving yourself a shot of adrenaline, a jolt of adrenaline, right? So in that first 24 hours, I easily did it 100 times, probably more. And when I really paid attention to it, I was stunned because I'm a really positive person. I mean, if you attend these meetings, you know I'm a really positive person. The next day, I did it about 50 times. Day after that, we did it about 25 times. 5 days later, I was doing it once a day. And you know, for the first time in 15 years, I was at peace. I was stunned that I had been living in this adrenaline stew for 15 years. I mean, it pretty much started as a kid, longer than that, you know, with the bully. So it's important that you not blame yourself. This is not your fault. You know, there's this great quote here. Where is it? I have it. I keep it right here. It's not about what's wrong with you. It's what happened to you, right? So nobody's saying that you're wrong. They're saying that something happened which triggered the anxiety and the fight or flight. So we do have to make a concerted effort to pay attention to those negative thoughts and be aggressive. Stop sign, deep breath, minimize the thought. I went through emergency surgery for uterine cancer, didn't have a panic attack. What was I doing on the way to the hospital? Stop sign, deep breath, minimize the thought. I have not had a panic attack, knock on wood. Now, see, I just did it. I just had a negative thought. I got to do it. Stop sign. Oh my God, Jill, you're not God. For all you know, tomorrow's going to be a great day and you're never going to have a panic attack again, right? So you got to pay attention to those negative thoughts. And as soon as you catch yourself doing it over and over and over, you got to work on that. Okay. Kathy says, do they sell Bladder Smart in a trias size? No, none of the supplement companies have freebies. None of them do. I've asked every single supplement company to make small sample packs, and they just can't do it. It's too expensive. We're long past the days where pre-leaf. We used to have a lot of samples of pre-leaf. They don't make samples anymore. Although I think it might be working on small samples of like 4 pills. Elizabeth says, have you heard of bladder parasites, specifically schistostomatosis? I went to get my urine tested, but my urologist says it's not necessary and won't order it. I've stayed in China. I know it's a long shot, but I'm about to shell out thousands for surgery and recovery. Might as well rule something out with a simple P test. You know, you could call Microgen and see if their test might find parasites. I honestly don't know. I will tell you, I saw the craziest video this week of a surgical video. They had tied off the appendix to remove the appendix. And when they cut into the appendix, worms came out. It's so disgusting. It was a little sliggling, you know, and they knew what type of worm it was. It was somebody like in the Middle East. Is a very not common in the U.S. You know, the U.S., Canada, et cetera, et cetera. So you know, I don't know anything about it, hon. I just don't. Elizabeth says, I think I have high estrogen levels. I do have endometriosis. Does high estrogen affect IC? TMI, but I've always had great lubrication during. Hey, girl, power to you. No shame there. I've never heard of high estrogen affecting IC. I mean, we have a group of patients who flare when their estrogen is low, and a group of patients who flare when their estrogen is high. Although that's a pretty small group. I think what you would have to do is track your symptoms over time, and see if you flare. Match your flaring with your menstrual cycle. We do have our new BladderTracker app that you can use to do that. Let me go get my phone. I should have had it in here. Hold on. Oh, I'm so sore. Oh. All right. Oh my God, I'm so freaking stiff today. Like, holy moly. That's what I get for walking 7 nights in a row. I should have taken a break. Let me show you our new app. This is a free application that you can use to track your symptoms. It is called BladderTracker, and it is available in the Google Play Store and the Apple Store. There are a very small group of people, small handful of people are having trouble registering. We're not quite sure why on the Apple side, but quite a few patients are doing it correctly. Again, it's a free app, and it's a work in progress. The cool thing about this app is it will allow you to track a lot more than just your bladder symptoms. So let's do it. The first cool thing about the app is that you never have to enter times or dates. That's all tracked. So the first thing it's going to ask you is, what's your overall wellness? How you doing? Just how you feel right now, right? And you click log new entry, and it's like, okay, you feeling good? You feeling that? Or you feeling bad? I am definitely here because my pelvic floor is, okay, and then you click log entry. Our next episode is right here. We're going to track urination. So we're going to log a new entry, and it's going to say, are you having pain before urination, after urination, and how is your stream? So for me, I'm not having any issues before urination, but you can do mild, moderate, bad, excruciating. So I'm not having any pain before urination. After urination, I'm having just a little tiny bit of pain in my perineum. I can feel it right now. How is my stream? My stream is strong, moderate, weak. I'm going to say moderate because, again, my levators are not happy with me. Did it wake you from sleep? You can log that too. And the answer is no, I'm awake right now. So I'm just going to say no. Then we can go to stress level. How's your stress level right now? My stress level right now, because my body is not happy, I'm going to say is moderate. How's your pain right now? I'm going to log my entry. And what's cool about this is that it asks about bladder pain, pelvic floor pain, lower back, rectum, urethra, perineum, vulva, tip of the penis. I'm going to say, I always rotate between pelvic floor and rectal pain. Nah, I'm just going to say rectal pain this time. And what's it feel like? It's just a aching. Okay. Okay. You can log what you're taking if you want to see how you're doing over time. And because this is our partner in this was Natural Approach Nutrition, the company that makes Bladder Builder and Bladder Rest and My Daily Manos and Peora and all those wonderful products. So we already have built into the app their supplements because they are definitely the most popular supplements right now. And so I take Peora, and I take 2. I took 2 last night, and I'm going to say track. You can track what you've eaten and drunk. You can track your hydration. So what have I drunk today? Actually, you know what? I'm way behind on drinking. I haven't drunk any water, and I haven't even drunk enough of this. So it's 2:30, and I've only had 1 glass of water. That's terrible. You can track your exercise. I've been hitting it hard, exercise, and I'm paying for it right now. So I did hard exercise for 1 to 2 hours. Yep. Etc. So bladder, and then the cool thing about this is that you can then do an analysis, and you can do a single day analysis, or you can do a 30-day analysis. So there's my 30-day analysis. And then you can generate a report and email it to yourself, and so that you can give it to your doctor and put it in your medical record. This is a really good thing to do if you ever think you're going to need some disability benefits. It's good. It's a good indicator of how you're doing. Samantha says, I was on Zoloft for depression, but I told the doctor it gives me pain in my bladder. He took it away. I tried many different types of non-serotonin antidepressants and not work. I ended up taking TMS and only works a little. Now I want to go back on Zoloft, but the doctor won't give it to me. Has this happened to someone else? You look for another doc to get the meds for your mental health. Yeah, you really should be working with a psychologist maybe, or a psychiatrist who might be able to help you a little bit more with your depression and the appropriate medications. Shirley says, my dad and I both have Hunner's lesions. That's very interesting. Jennifer wants to know the name of the anxiety class. It's called Phobies, like phobia, Phobease, Phobies. Amy says, I'm ready to have my bladder removed. Amy, you know, we only really talk about bladder removal if your bladder's really, really small and scarred and not stretching well. Have you done, a lot of patients, myself included, my first year, I actually begged the doc to take out my bladder my very first year. And he's like, no, I'm not taking out your bladder. You haven't done anything yet. I mean, all I had done was a couple of DMSO treatments. And I was like, can you take it out? And he goes, no. All I can say is thank God, because other therapies really did work for me. Mostly physical therapy, you know. Vicky says, I think negative thoughts are caused by brain inflammation. The best I've ever felt is a week before last, after I had a fever from COVID. Baffling. So you guys, several of you are sharing that you have Hunner's lesions. I have a whole area on our website, icnetwork.org, about this. We also have a separate website, hunnerslesions.org, that I run for that. Hunner's lesions are now considered its own separate disease. We call this Hunner's lesions disease. And they are going to be broken out away from the other quote unquote IC patients. Although in Europe, only patients with Hunner's lesions are diagnosed with IC. Everybody else without Hunner's lesions are called bladder pain syndrome. We're starting to do that in the United States too. But there is a very, very clear consensus among the top doctors and the top researchers that Hunner's lesions represent a completely different and unique disease, and that you need your own research. And so sooner rather than later, you're going to see that break. Understand that Hunner's lesions are filled with inflammation. What makes a Hunner's lesion unique is that when you biopsy it, it is absolutely filled with inflammation. This is a war. This is a biological war happening inside those tissues. People without lesions do not have inflammation. People with lesions have inflammation. And so now we have a clue as to what could be causing that, because we have now made a very clear connection between the polyoma BK virus and the polyoma JC virus with Hunner's lesions. It was the Europeans who discovered that patients with lesions have a virus in their urine that patients without lesions do not have. That research was then replicated for several years here in the United States. And again, last year, the National Institutes of Health published a very similar study that a small subset of quote unquote IC patients have polyoma viral infections in their bladder. We certainly know that viruses can infect the bladder. Polyoma is a virus we all have. It's part of the virome. The reason why it gets turned on in some but not all patients is because of immune suppression. Therefore, we see polyoma infections in people who are immune compromised. We used to see a lot of that in HIV patients, but they also see a lot of that in patients on immunosuppressant drugs for kidney transplants, et cetera, and anybody who's just immune compromised. So, having a next generation urine test to see if there might be an active viral infection would be one thing to consider. Also understand too that Hunter's lesions do not respond to Elmeron and bladder installations to any great degree. Lesions require lesion-specific therapy, and that is fulguration or laser therapy to close the lesion, because a lesion is the equivalent of a bloody open wound in the bladder, and urine in that wound hurts, right? And so they're going to either laser that wound closed, they're going to, or fulgurate it with heat to close it, basically to cauterize it, or they might inject a steroid into the middle of that lesion, or they might do hyperbaric oxygen therapy, or they might do, well, we used to be able to do Lyris. Lyris is the only treatment in history to heal Hunter's lesions in 2 weeks. Unfortunately, the company that owns Lyris, Allergan, is not making that available to anyone right now. Michelle says, how can you tell the difference between bladder and pelvic floor pain? The easiest way to tell the difference is pain on fill. If you have pain as your bladder gets fuller and fuller and fuller, and you feel better once you empty your bladder, that's your bladder wall. That means that you've got something wrong with your bladder wall. Thus, as it gets fuller and fuller, urine is now getting into the wounds in your bladder. The fuller you get, the worse you feel. And when you empty your bladder, there's a profound sense of relief. It's, oh, thank God I found a bathroom. Because urine is no longer into the wounds, right? So if you have pain as your bladder fills with urine that is relieved by urination, that points us to your bladder wall. If you have pain after you're done urinating, that points us a bit more to the pelvic floor. But of course, every patient is different, and there's, it's kind of there's very subtle changes and differences in the symptoms that we have. Another thing that we look for specifically with pelvic floor, the pelvic floor, tight pelvic floor muscles can have a burning sensation in the vagina, around the rectum, and the perineum. It can be a pulling sensation, like somebody's trying to pull something out of your body, or a dropping sensation. Or it can be a pushing sensation, like something's pushing up inside your body, or there's something stuck in your bladder, or stuck in your vagina, or stuck in your rectum. Those are all pelvic floor symptoms. But the hallmark symptom is, can you start your urine stream right away? When you sit on the toilet or stand in front of the toilet to pee, do you pee quickly? Or do you hesitate 5, 10, 15, 20, 30 seconds before you can release urine, right? So if you have hesitation in urination, then we're definitely going to be looking at pelvic floor. So, bladder wall pain, very sharp, very shrill, feels like knives, feels like witch's fingernails coming down your bladder wall, very, very intense, sharp pain. Pelvic floor pain, duller, achier, burning, pulling, pushing, et cetera, et cetera. What is Peora? Peora is, I'm going to be hobbling the rest of the day. My thighs are so tight right now. It's ridiculous. All right, Peora, Peaora. So Peora stands for PEA stands for palmitoyl ethanolamine. PEA has been used in Europe for many, many years for chronic pain. There are dozens of research studies with it. They have studied it with fibromyalgia, with sciatica, with burning mouth syndrome, acute pain, chronic pain. And a couple of years ago, in 2019, they actually brought the data from an ICPEA research study that was nothing short of remarkable. That study that was done in Italy found that PEA, at 3 months of use, 87% of patients reported a significant reduction in their pain. And by month 6, I think about 25% were completely pain-free. The consensus among the researchers is that PEA is remarkably successful at calming nerves down. And we did have pharmacists in Southern California who were importing PEA years ago, 20 years ago. It was just too expensive. So we just kind of forgot about it. But now with this new study, it's become central, especially with the subtypes. Now that we know about IC subtype 5, where we have to calm nerves, and so Peora is what I take when my central nervous system is getting tweaked, and it got tweaked 2 nights ago. It's interesting, or after work, it was weird. I start feeling pinpricks. They call it paresthesia. I'll get a pinprick here, then I get a pinprick on my leg, and then I get a pinprick on my back. And my nervous system has just gotten extremely sensitive. PEA has changed that dramatically. I mean, that's the first little mini attack I've had in over a year, and it was because of a specific thing. Oh, I know what it was. Like I had a bug bite or something, and I was scratching it really hard, and that just triggered all of my nerves. But generally, PEA, the cool thing about it too is it's a fatty acid, very, very easy on the body. No side effects reported in the IC study. I'm the side effect queen. I've taken this every night for over a year. Never had a flare from it. And so if you're like me, where you've got more of the central sensitization, chronic overlapping pain conditions, it might be interesting to try. But you got to read about it. You guys listen. You got to do your due diligence. If you go to our website and go into our store, you can look at Peora, and you can copy and paste the scientific name, palmitoyl ethanolamide. I can write it. Let me just write it, and then I'll give you the link, and I'll show you exactly where to do your research. So here, palmitoyl ethanolamide. So. All right, so you guys on YouTube, there's the scientific name for it, and here's the link. Go to that link, copy and paste that in, and you look at the research. You see what you think. All right, Facebook, I'm going to do the same thing for you. Jennifer, I don't know if you can take a screenshot. If you can take a screenshot and email that to me, I'll email that to the developer. You're the first person who said it wasn't working on an Android device. Oops. Julie says, do you think 2 Kenalog injections a year is bad? No. I mean, is this a long-term life I need to be prepared for? No, listen. We always have to focus on the concept of cause versus effect. That if you're struggling with severe pain, you can't just keep focusing on the pain. We have to try to understand what's causing the pain. Because if we know what's causing the pain, we might be able to treat that and make the pain go away. So as an example, when you treat a Hunner's lesion, the pain improves dramatically in the great majority of patients who do it. And then understand too that lesions do randomly disappear. So can anybody say this is lifelong? No, nobody can predict the future and say that it's lifelong. I think what we can say is that for patients who don't protect their bladder, for patients who you've got a wound in your bladder and you're still drinking coffee and soda and bathing that wound in acid, you're in for a long-term discomfort, because nothing can heal if you pour acid on it every day. Worst thing you can do is do that. Is Peora costly? No, it's the cheapest supplement we have. It's $24.99. It's made by Natural Approach Nutrition. You can get it from our store on the IC Network website. Becky says, I love Peora. It helps me a lot. Megan says, in your opinion, which estrogen topical cream is the safest and the least irritating to use? A compounded estrogen cream that's propylene glycol free or preservative free. All right, so for those of you on Facebook here, let me just spell this out. There's the scientific name. I want you to cut and paste that scientific name and go over to PubMed and look at the studies. I think you'll be very, very impressed. I was extremely impressed. Julie said, so I should stop the coffee and all the foods after I have the Kenalog? No, you should stop it before you have the Kenalog. You listen, girl, if you have Hunner's lesions and you're drinking coffee, you're making a catastrophic mistake. That is a big bloody open wound in your bladder. That's the worst thing you can do. You got to lose the coffee now. You know, you got it. Your job is to create an environment to support healing. And so ideally, it would be ideal for you to be off of coffee for at least 5 or 6 months. And that means no tea, no green tea, no soda. It means water, milk, chamomile herbal tea, peppermint herbal tea, or rooibos tea, or maybe dandy blend. But you got to back way off on the chemical irritants in your bladder to try to give your bladder an opportunity to heal and repair itself. Sylvianne says, I'm on Bladder Builder and it is great. It is a great help. Could I take PRO with it? Well, Bladder Builder already has PEA in it. So the answer is you don't need to. Susan said, what's the spelling? Susan, I just put it in there. Palmito oil, ethanolamide. Jennifer says, the IC diet has been my best friend. Yeah, it's important. You know, it's important. I think fundamentally, and especially now with the biopsy results, and we're really understanding so much more about the anatomy going on, that I see in the form of Hunner's lesions, subtype 1 Hunner's lesions, is a disease process. There is a strong response happening in that lesion. The body is clearly fighting something. But for the rest of us, if genitourinary syndrome of menopause, chemocystitis, pelvic floor, pudendal neuralgia, central sensitization, biopsies do not find inflammation. And when you think about the bladder wall, and we think about the things that can irritate the bladder wall or injure the bladder wall, because hello, the bladder can be hurt like any other part of the body. Generally, it's hurt through exposure to chemicals. Chemotherapy or way too much diet soda or soda. Those are going to injure the bladder, or smoking. Smoking will injure the bladder. Smoking, that was our IC Awareness Daily Fact number 29. It was the last fact before the end of IC Awareness Month. The worst thing you can do, think about it this way. If you have Hunner's lesions and you have a big bloody wound in your bladder and you're smoking, all the carcinogens from that smoke will end up in your urine and they will pass deep into the tissue through the lesion. Smoking is the #1 cause of bladder cancer. You're dramatically increasing the odds of those carcinogens getting deep into your tissue if you happen to also have Hunner's lesions, right? And the same is true with if you got genitourinary syndrome of menopause, where you got estrogen atrophy. Your bladder doesn't have that nice thick coating of mucus that it would normally use to repel urine and to prevent the toxins in urine from reaching those cells and damaging those cells. So smoking really is devastating. The other thing we know, and this might stun you, is that anybody who is exposed to secondhand smoke can also develop bladder symptoms, especially the children of smokers. If you smoke in the car and you got your children in the car and they are breathing in high quantities of smoke, research proves that they are going to get the symptoms of IC, frequency, urgency, pressure, pain, as a result of the cigarette smoke exposure. We have made that correlation. So the best thing that you can do for your family, seriously, is lose the smoking. Stop giving your money to a company that has killed millions of people over time, right? And will continue to do that. It's tragic. It's just so tragic. Jennifer says the farmer's market's been my other one. You know, I haven't been to our farmer's market in 2 years. I used to go every weekend, but with COVID, they shut it down for a year, and now it's back. But I don't know. I haven't really been into it. Susan said, that's because I use imperfect foods and I get organic food. I get organic food delivered to my house, and it's good. Imperfect foods. Chimera says, I'm a little late, but I wanted to thank you for that app. It is amazing. I've started a 5-minute timer when I walk into the restroom to track my stream. And it also forces me to leave if I can't void. Excellent. That's so important that you not sit on the toilet and strain and strain and strain and strain. You're just going to screw up your muscles big time, big time. Susan says, I found Peora. Thank you for all you do. I was diagnosed at 21, 40 years ago. Hey, Susan, we're the same age. I'm 61 too, and it has controlled my life and diminished it severely. My husband and I decided not to have children because of how bad my pain is, not to mention flare-ups and the medications I try to take to control the pain, which barely even touches it. So, Susan, here's the harsh reality. Everything we knew about IC 40 years ago when you were diagnosed and when I was going through it myself, all that information has been thrown out. We no longer think of IC as an incurable bladder disease. We think of IC as a pelvic pain syndrome. Why? Because structures outside of the bladder are often involved, whether it be the pelvic floor muscles, something wrong with the uterus, something wrong with the spinal cord, like Tarlov cyst coming off the spinal cord, or even the central nervous system, right? The central nervous system. And so if you have IC and IBS and or vulvodynia and or migraines and or TMJ and or fibromyalgia, the fact that your pain has gotten worse over time tells me you probably are in this group. Then you have what we call chronic overlapping pain conditions. And that's a central nervous system disorder. I'm in this group. I'm absolutely in this group. If you email me, icnetwork@mac.com, anybody out there, listen, if you email me and you have multiple pain conditions, please email me, icnetwork@mac.com. I will send you our winter magazine, which has now told us exactly why this happens. We know why this happens. That in 80% of the people it happens, there is a significant physical injury. Then in 20%, there is either abuse or bullying. And it's called a central nervous system maladaptation. It's nobody's saying it's mental. Nobody's saying you're mentally ill. It's not a mental illness. It is a maladaptation that the brain is stuck in fight or flight. And we know how to fix it. There's great hope. We know how to fix it. So now we know why a group of patients did Elmeron for 20, 30 years and never got better. Because it wasn't their bladder. It was something beyond the bladder. And again, if you've got the multiple pain conditions, then we're really looking at chronic overlapping pain conditions. And we're looking at an amygdala in your brain that is stuck on, and we have to turn it off. And we know exactly how to turn it off. I don't know how long you've been here, but we went through this about 45 minutes ago. We know how to turn it off with good sensory information. And I'd be more than happy to send you our article on this. We also have articles on our website, icnetwork.org, and also in our new book, Stay. IC 101. It's not just a bladder disease. And so this book is available for $9.99 on Kindle. It is as a PDF file on our website for $9.99. If you want the print version, it's $24.99. You can get it from us. You can get it from Amazon. But please get it from us. It would be better. It's easier if you get it from us. And so these books go through this in depth, along with our subtyping, along with another new discovery we've made, and that is something called small fiber polyneuropathy. We now know that the smallest fibers in our skin, for those of us who have really, really sensitive skin like me, the smallest in diameter nerve fibers are not behaving normally. Small fiber polyneuropathy. And they can prove that with a very, very simple biopsy of skin on your leg. And there are specific treatments for that too. So, so Sylvianne says, I have IC, IBS, migraines, fibro treatments with Botox. Yeah. So, hon, you're in the chronic overlapping pain condition. And so, seriously, number one, This is not your fault. You have done nothing wrong. Absolutely nothing wrong. No shame, no blame. It means that your central nervous system has been traumatized. And it's either been traumatized by some sort of physical injury or it's been traumatized by abuse or bullying. And as a consequence, what that research shows is that you're stuck in fight or flight, and it's very, very difficult. Helen says Facebook is cutting out badly. Honey, Helen, you can come over to YouTube. We're broadcasting also on YouTube. They're on completely different internets. You can come back afterwards and you can listen to it also on YouTube or on Facebook, okay? Jana says, oh my goodness, you just described me. Yeah. I mean, it's just so cool now. It's so cool. I mean, like, seriously, in my 20s, I didn't understand it. It's just like, what the hell is happening to my body? First it's my bladder, then it's my bowel, then it's my skin, then it's my stomach, then it's this, then it's that, then it's the migraines, and and when you're in the middle of this, you feel so freaking crazy. It's like, what is happening? And the people around you are just as baffled, and your doctors are just as baffled. And I remember one day, I said to my mom, I said, I feel so bad right now. I feel so physically bad right now, but I don't know why. I just didn't know why. And I used to have what I call sick all over days, where I just felt so ill that I would have to lay down, but I couldn't explain it. And that doesn't happen to me anymore. I think that part of that, at least for me, was related to allergies and mast cells, because I remember I had Dr. Parsons up here in Sonoma County for an IC conference. We were at dinner with a group of people who were involved in the conference, and I was sitting next to him, and he goes, Jill, do you have allergies? And I went, yeah, I do. He goes, you should try hydroxyzine. We don't really understand why it's working, but it's really helping a lot of people. And I was like, okay. I tried the hydroxyzine. Within a week, my sick all over days were gone. They were gone. And I thought that was fascinating. I ended up taking hydroxyzine for about 10 years. Oh, John, thank you. John says you can solve the Facebook cutouts by moving the live slider about 30 seconds behind live. That will stop it from cutting out. Thank you so much, John. Appreciate that. So, the single most important thing I want you to remember from what I'm saying to you right now is none of this was your fault. None of this was your fault. There's nothing wrong with you. It's what happened to you. That at some point in time, your body was traumatized. And now we know what to do about that. For the patients with intense anxiety disorder, we know what that is. That is a brain stuck in fight or flight. We know how to stop it. We know how to fix it. I have not had a single panic attack since I took my phobies class 25 years ago. I never let the negative thoughts get out of control. And let me tell you, it's been hard with COVID. I used to do the stop sign, deep breath, minimize the thought once a week. Well, I was doing it once every couple of days, with COVID and all the stress with COVID. Shirley says, my dad and I had severe allergies. Yeah, so it would be very interesting for you guys maybe to think about trying the hydroxyzine and seeing if that makes a difference. There's two forms of hydroxyzine. There's hydroxyzine hydrochloride, also known as Atarax. There's hydroxyzine pamoate, known as Vistaril. Between the two, the Vistaril, the hydroxyzine pamoate, that's P as in Paul, AMOATE, is a purer form that's easier to tolerate. I took one Atarax and knew I couldn't take it. I had a very strong reaction to it. And I don't even remember what it was. I don't remember what it was, but I knew I couldn't take it. So the doctor switched me over to the Visceral, and that worked like a charm. 10 years, it was great. The challenge with the Visceral, Visceral has, so it's an antihistamine. It acts to calm inflammation. To calm mast cell activity and histamine-induced irritation throughout the body. Of all of the antihistamines, it was found to be the most effective at the bladder level, reaching the bladder, which is why it's suggested in the AUA guidelines for IC as a step 2 treatment. It has a very nice beneficial side effect in that it also has a very nice anti-anxiety effect. So if you're struggling with anxiety, that'll give you a little bit of extra oomph in trying to calm some of that anxiety. It only really had, at least for me, a couple of side effects. I was much more heat intolerant. In the old days, I loved 100-degree days. I used to play tennis tournaments at 105, and I was in my glory winning those tournaments. I loved it, drinking a quart of Gatorade per set. It was so hot, but my body loved heat. But after using Visceral, I got sick if it was over 90. I just felt ill. The second thing that hydroxyzine does is it changes your dreams. You have more vivid dreams. So if you're having a sex dream, it becomes a best sex of your life with the hottest movie star you've ever fantasized about. Right? Okay. I had that dream a couple of times. But if you're also having a nightmare, it becomes a night terror. And that's why I had to stop it. I started having a one night in particular, I had a vicious dream of my family being killed. And it was awful. And like my cat being killed in front of me. And I knew immediately what it was. It was night terror from the medication. Stopped the medication, never happened again. The other issue with hydroxyzine, as well as amitriptyline, as well as any other anticholinergic medications like the anti-overactive bladder medications, Detrol or Diatropan, is that they are linked to cognitive decline. If you are taking, here, hold on a sec. Got an error message here. If you are taking anticholinergics every day over time, that significantly increases the risk of cognitive decline and dementia. And that research started in Europe more than a decade ago. It was originally believed to affect seniors. If you over the age of 50, appeared to be more at risk of cognitive issues taking anticholinergic medications. But then we had a research study which showed that same cognitive decline was happening in people under the age of 30. So anticholinergic medications, more is not better. All I can say is I took hydroxyzine for 10 years. I stopped and started it frequently. Sometimes I went months without using it, and then I started using it again. I took a quarter of the lowest dose. The lowest dose of Atarax is 10 milligrams. The lowest of Visceral is 25 milligrams. It comes in a capsule. They had me open the capsule, divide it in a cup of water, and I drank a quarter cup of water. And at the most a half a cup of water. So I'm very, very grateful that I used very, very little. There are some medications that are not anticholinergics, like Myrbetrix, Mirabegron for urinary frequency urgency, that is a viable option. So you got to look at your overall medication use. If you're taking a lot of anticholinergic medications, you are potentially upping your risk of cognitive decline. Deborah asked, do I take antidepressants? No, I took Elavil for 3 months in 1993. It wrecked me. The challenge with Elavil, aside from, dry mouth, dry skin, is for some people it affects our heart. And for me, it affected my heart. Elavil can change the conductivity of some of the heart tissue. And so what it did for me, now again, guys, I'm a redhead. I'm super sensitive anyway. I'm wired differently than other people because of my red hair. What it did for me is it activated a third node in my heart. So normally your heartbeat is beep, 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 because you got your AV node and your SA node controlling heart rhythm. My heart rate was beep, 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 beep. And sometimes it was beep, beep, because two of the nodes would beep at the same time. And that lasted for about 5 years. After 3 months, I had to wear heart monitors, and oh, holy mother of God, was that brutal. John says, I found nasal crumb to be quite helpful for allergies. Ooh, John, thanks for sharing. Ann says, can you go off the estrogen cream cold turkey? Sure. I would talk to your doctor about it. Estrogen cream is not known for causing any sort of tolerance or anything like that. So, ask your pharmacist, but I don't believe so. But, double confirm it, double confirm that. I mean, I tend to be pretty passive aggressive with my estrogen cream. I will forget to use it for 2 weeks, and then I will use it 4 days in a row. I don't believe there are any issues with that. Sierra, I got your address. Thank you very much. I will get that out to you tomorrow. Zelda says, is there a consensus that fibromyalgia is a fight or flight issue? I think so. I think that all that research is pointing directly to the central nervous system and directly to the brain and an overactive amygdala. The amygdala in the brain is the structure of the brain that controls fight or flight that only gets turned on in fight or flight. And so if I remember correctly, I think it is. I just got an email from you guys, I'm so excited. You think this is going to work? The Publishers Clearinghouse Prize Patrol says we're ready to deliver $7,000 a week for life. Your selection is imminent. Do you want to win and have us deliver this to your home? Yes or no? Did anybody win the $650 million Powerball yesterday? Let's look. I want to look. I put $20 down on that. Are you kidding? That's a great fantasy. Did anybody win? No. Oh my God, nobody won. It's now at $670 million. The next draw is Monday. Estimated cash value, $474 million. All right. So my plan, this is my plan. I have thought about this. I'm telling you right now, this is a fantasy that I enjoy. That if I won the lotto, number one, you start a private foundation, which you can do. And then the private foundation, nobody knows your name. The private foundation collects it, right? What I would do is I would create a family trust, and I would create a research trust. And the family trust would be for lifetime care for family members, as well as making sure everybody has a home to live in. But the research trust would be dedicated to researching IC and also doing things like scholarships and helping people pay for their procedures and medical care. I have this great fantasy. This has been my fantasy from day one. It's like I would love to buy an apartment complex and have it be a sanctuary for IC patients, and especially for people who are single and who don't have the support. I would love to do that. Have a garden in the middle, pool in the middle. We could all hang out during holidays, be there for each other, take each other to the doctors, shop when necessary. That is like my fantasy. I would love to do that. I would love to do that. I don't care about fancy cars, fancy houses. I don't need a fancy house. Man, come on. I live in a 1-story, 3-bedroom, 2-bathroom house with my elderly parents who I care for. I'm perfectly happy with this. I don't need anything bigger. And I sure as hell don't want fancy food or anything like that or fly around the country. I don't need that. I just want to laugh. I want to hang out with my friends. I want to play games. And I now starting a bed and breakfast, that would be kind of cool. I wouldn't mind doing that too. Anyway, that's my fantasy. Uh-oh. Okay. Oh, did I plug in the wrong mouse? Hold. Oh, dang it. Oh. I now do not have. Okay. Okay, hold on. I plugged in the wrong mouse to the wrong computer. So hold on. Now I got to unplug this. Now I got to. Okay, hold on. And I did. Oh, I can't believe I did that. Okay. Alrighty. So now, okay, now I got my bad mouse on Facebook and now my good mouse on YouTube. Yeah, it's a good dream. I mean, it'd be nice to have retreats for IC patients. It'd be nice to have a medical retreat where we could all come to, again, you know, like a small country hotel where we can take classes on IC or pelvic pain, have a doctor there, have nurses there, and really give people free medical care that would really help them try to solve the mystery of their pain, right? That is my fantasy. Damn it, I'm going to make it happen somehow. I swear to God, I'm going to try to make it happen. Don't tell me no. All you got to do is tell me no, and I'm going to try harder. Jeannie says, I just found out on Friday I have Hunter's. It was through a cystoscopy. There was no hydrodistension. I'm a bit confused. Can you find out if you have Hunter's through cystoscopy? Yes. There are certain types of cystoscopes, specifically a narrowband imaging cystoscope that absolutely can identify Hunter's lesions through a cysto. So the question now is, Jeannie, what's the treatment plan for those Hunter's lesions? Because they cannot treat the lesion with the cystoscopy. Megan says, you're going to win. Reason you want to do it. I have a good feeling about it. I just have a good feeling about the future. Knock on wood. All right, guys. Well, gosh, we've been going for about 2.5 hours. Any last questions? Anybody else got any issues? I do have a new foreword for IC 101. Dr. Eckenberg read the book. He loved it. It's our top pelvic pain doctor in the United States. So he has actually rewritten his foreword. So I'm going to be putting that into the book in the next edition. So IC 101 is the first book that talks about subtyping so that you understand the different variations that potentially can play a role in your symptoms. And I'm being pretty aggressive with that. You know, I mean, you got to understand that the top researchers and the doctors are they love the research. They love research. And I love research too, but I'm also very, very practical. So when I sat on the U.S. Army Research Panel as the IC representative, my job was to remind them that patients were waiting for help and that we could follow obscure lines of research for 20 or 30 years about how does this happen? How does that happen? And in the end, it's missing the most important thing we have to focus on, and that is, what can research do for you? What can research do for you? How can we give you new treatments? How can we reduce your pain? And so in writing this book and talking about the subtypes, you know, I'm going against form, so to speak, because the leaders of the IC research movement in the United States, they're very research focused. They want the proof. So they're willing to go to bladder centric and beyond bladder, which is huge. I mean, that's just in the last year. Up to that point, they were going, everybody has a bladder disease. Now they're absolutely saying, no, some people have bladder issues, but many other people have issues beyond the bladder. I use a Chris Payne subtyping system because I think it is the most effective at educating patients and helping you understand why some therapies work and why some therapies don't work. So, for example, if you have Hunner's lesions, is Elmeron going to help you? The general consensus is no. So please don't spend 20 years on Elmeron. I mean, we know that. If your symptom is primarily pelvic floor driven and you sleep through the night and you're not diet sensitive, again, there's no reason for you to be doing bladder therapies. If you're sleeping through the night and you're not diet sensitive, then it's not your bladder. It's something else. Again, usually your pelvic floor. Then in contrast, if you've got chemocystitis from going through chemotherapy, then yeah, we absolutely know your bladder wall's injured from the chemicals of the chemo, and your job now is to try to eliminate the irritant. That means we got to get through the chemo, and then create an environment that will support bladder healing. That means you got to lose the coffees and the sodas and anything else that's potentially irritating to the tender, fragile tissue that has been irritated and damaged by the chemo. And so, you know, every single patient is an anatomical mystery to be solved. We cannot practice generalizations. There are some people online who say everybody has UTI. That is wrong. That is absolutely wrong. Not everybody has UTI. Some of you have fibroid tumors pushing on your bladder. Others, you know, have a broken tailbone healed the wrong way. Some of you might have a spinal cord issue. Others have chronic overlapping pain conditions. You know, so we don't make generalizations or sweeping statements anymore. You are an anatomical mystery to be solved. It is the snowflake principle. Every snowflake is different. Every IC patient is different. And that is indeed why being in a support group is very, very challenging online, because you simply don't know what their subtype is. You cannot compare an apple and an orange and banana. God forbid you walking in with mild estrogen atrophy, your bladder wall's just a little bit sensitive, and you walk into a group with a Hunner's lesion patient who's in agonizing pain, it's going to scare the hell out of you. But you don't have Hunner's lesions. You got mild estrogen atrophy. It's not the same thing. Jennifer says, have you ever heard of a Kickstarter campaign? I have. Just not, just not quite. I'm not quite ready to do it yet. You know, I'm doing elder care, and I think that is my other full-time job, and I just can't add anything else. But as time passes, I'm going to be able to do more. I don't want to say more than that. You know what I mean. Jeannie says, are you going to do a Zoom? I need to go in there and ask questions. Jeannie, I'll be happy to open up Zoom. Allison said, they did a biopsy on my bladder. Okay. Julie said, maybe there are enough people to share your beautiful ideal and would come together with shared finances. I'd love to be a part of that. Maybe doctors who treat these patients. Yeah. I mean, honestly, we really, 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 really need to think about the future. What do we want? What do we need? What do we want? Because seriously, nobody's going to do it for us. We've got to ask for it. Zelda said, can't believe you said that I had a broken tailbone that healed crooked. And I was right. Was I right, Zelda? Hello, Beth. Beth, I don't know if you're related to a lovely woman named Carol Hinsey, but she was my tennis coach back when I was playing tennis. She was a good woman. We just lost her last year. I ran into her like 2 years ago, eating alone on either Thanksgiving or Christmas Day. And so I went to the owner and I paid for her. I paid for her meal, and she had no idea it was me. Yes. And then she finally looked around and saw me, and she walked over and she said, did you pay for my dinner? And I was like, yeah, I did. It's from all of us to you. Enjoy it. And she was like, thank you. She didn't like me very much, actually. I was a bit of I was a bit of a beast back then. I was young and immature. All right. So let's do this. I tell you what, I'm going to go ahead. Oh God. Okay, hold on. The Zoom has been screwed up. Let me see if I can set it up. So with the Zoom meeting, you can come in and talk to me and get some coaching. But I accidentally screwed it up 2 weeks ago. So let me see if I can start it on this computer. Otherwise, I got to go to the other computer. Hold on. I don't quite understand what I did. Okay, hold on. I did finish the, I built 2 new websites, and now I'm building the COVID associated cystitis website. I started that last night. All right, so hold on.
Recording in progress.
It worked. Okay, it worked. All right, so this is what we're going to do. I'm going to post the links for Zoom on YouTube and Facebook. And what we're going to do then is anybody who wants to come into Zoom and ask me personal questions, just come on in, because I will probably within 10 or 15 minutes shut off Facebook and YouTube and just stay in Zoom. All right. Zelda says, I've learned so much today as usual. Oh, thank you. I don't have time to do as much reading as I would like to do. There's so many more things I would like to be reading. Okay, so there is the join link on YouTube. All right, now for those of you on Facebook, wow, I got so many windows open on that computer. It's ridiculous. Okay, hold on. Let me get you your link. And again, it's already been a little bit distracted today, but my legs are on my pelvic floor is not happy with me because I did a really long walk last night after dinner. All right, so let me copy this. All right, now Facebook, here is your invitation into the Zoom meeting. And if nobody wants to do it, that's fine. I'm good. I'm good. All right, Facebook, there is your link. And you guys, if you find these meetings helpful, please think about becoming a member of the IC Network so you can get our magazine, because that's what basically pays for it. You know, we just have bills. I have bills I've got to pay, like health insurance. And so if you can come on over to our website and sign up to become a member, it's $25 a year or $50 a year or $100 a year, depending upon what you want. If you buy products from us, that really, really helps us in the long run, especially our new book, IC 101. And for anybody out there that I've already sent you the book as a gift, would you please, please, please send me your review? I would love to hear your thoughts on the book. Thank you, Laura. Thank you, Anne. All righty then. All righty then. Okay, so hold on. Let me check Zoom here. I've got Sierra's coming in. Did that link work? Sierra, hold tight, honey, okay? Don't say anything. Just try to stay I have to. Hold on a sec. We are waiting for. All right, Jeannie, did the link work? Jennifer, I got your email. Yes, I will send you that link. Sierra, I did get your mailing address. I will send you that book. And I have one more free book. Donna is the lady who made that happen. Donna Townsend was sending us a donation to support sending that book to some of you. Much appreciated. The link for Facebook, is it not working? Crap. Okay, so what I did, the way I got into the Zoom meeting is I went to our website, icnetwork.org. And then I went to support, and I went to the support page, and I clicked on the Zoom meeting link. So the Zoom meeting link on the website should work, because I use that on 2 separate computers to get into Zoom. Let me try. Here, you know what? Let me click on it on this computer. Allow this to open in Zoom. Hold on. Launch meeting. It worked. So now I'm in Zoom twice. Okay, so let me. I'm gonna close this one. Okay, so I know that link worked because I just did it. So let me copy that again. Okay, that link worked. Try it again. Mary says, I think all of us are different with this disease and pain. Absolutely true. Elizabeth says, how are torn ligaments holding the uterus up diagnosed? You know, it's really interesting. What they do is they use, okay, so hold on a sec. Oh, Jennifer, I see you. Okay, I just let you in, Jennifer. You should be in a second. Yeah, okay, so you're in. So what they do is they put a wooden speculum. Let's see, how can I, here, let me see if I can kind of draw a picture here. It's fascinating. So a lot of people think that when the cervix meets the uterus, that it's flat. Like, here, hold on. Okay, so a lot of people think that where the cervix at the top of the vagina, you have a cervix and you've just got skin that goes either way, right? That it's just a hole. But it's not. It has what they call a fornix. And so really there are, if I hold it this way, so if your finger were coming up here, if the doctor's finger were coming up here, they could touch your cervix, but you have a pocket here and here. They're called a fornix. And so what they do is they just put a wooden speculum in the fornix. And that will lift the uterus and put everything potentially in a better position. And so inserting a wooden speculum right here or right here resolves the pain, then we know for sure what's going on with you. All righty, so we have 3 people in Zoom. Brandy said, so you guys on Zoom, just one more minute. Mary, okay. Brandy says, have you ever heard of an ovarian mass triggering flare? Flaring for 6 weeks straight now with ovarian pain as well. Wondering if it would be best to just take out the ovaries. I've already taken out my uterus 14 years ago. Quality of life is very poor. Ironically, I was just working with another lady like 2 weeks ago. Same thing. And they did eventually take out her ovaries. I think you have to have somebody look at the ovaries and try to figure out what's wrong with them. Because honestly, the ovaries are an important source of hormones. And if you lose your ovaries, honey, I don't know how old you are, but I mean, when you lose those ovaries, you are immediately put in total menopause. And it's like you age 10 years in the first year. It's stunning the things that change. Having that little reservoir of estrogen in those ovaries over time is pretty important for your health. So ultimately, you're going to have to make that decision based upon what's wrong with your ovaries. If your ovaries are just, they just have to look at them, hon. They're going to have to figure out what's wrong with them. I certainly wouldn't make that a rash decision and pull them. If it's just one ovary, maybe they can remove one ovary, but they can save the other one that would still supply you with that little bit of estrogen. All right, so now I've got my people in Zoom. So I'm going to say goodbye to Facebook. Peace to you all. Love you dearly. I will see you on Thursday for our Facebook only meeting in the afternoon, if I can do that, barring fires. So for those of you on Facebook, thank you so much for coming. And I'm going to say goodbye to you. If you can come on into the Zoom meeting if you want to hang out a little bit more, just follow the link above. All right. So goodbye, Facebook. Let's see here. We're going to end that. All right. And YouTube, same thing for you guys, YouTube. If y'all want to hang out a little bit more, come on into Zoom. Otherwise, I absolutely wish you the best. And if you have any questions, please feel free to reach out to me, okay? So goodbye, YouTube. All right.